do it. So now I'm going to do this case, and then I'm going to see how well it works answering Q&A over the Zoom chat. Okay, so the next case, this is a 72-year-old woman, presents to your operating room for a Whipple. She's got pancreatic cancer. Other than the cancer history, she's got heart block that no one seems to know why she has it, but she has a pacemaker. She got her leads placed in her generator about 2 years ago. Her rep recently looked at it. It's functioning properly. Her EKG shows pacer spikes. Cardiologist says she is cleared for surgery. So now I was going to kind of fill this out with you guys. So let's start. I'm going to do this. And we are actually going to try to fill one of these out together. So first thing, this goes to the chat, or should they just put it in the Q&A then, I guess?
The chat's now been enabled, so they can
okay
interact with you in the chat.
Okay. All right. Any brave souls like to talk about the special considerations? What makes this patient special is the first question. Okay. So right. Great. Pacemaker. Okay. So patient has a pacemaker. So you bring up a good question. Is the patient pacemaker dependent? Somebody say yes or no. Great, everyone said yes. Okay, so the fact that the patient has pacer spikes on the EKG would imply that there's some degree of pacemaker dependency. I'll just put pacemaker dependent. Worth noting, we did kind of skip a step there. Someone did note that the patient was pacemaker dependent, or you guys did. You asked a question. One of the other question is, where's the electrocautery? So the issue with pacemakers is if there's electrocautery during the case, the pacemaker may interpret the electrocautery as electroactivity of the heart if it's too close. So the pacemaker may not fire when it's supposed to, or fire when it's not supposed to. Okay, so one of the questions you need to ask is, where is the cautery? So usually the rule of thumb is, if it's below the umbilicus, then it's probably fine. If it's above the umbilicus, you may get interference. The book answer, if you guys go back and look at the actual flow chart, the book answer is, the first question is, do they have a pacemaker or an implanted device? The second question is it above the umbilicus? If the answer is yes, the electrocautery, I mean, then the third question is the patient pacemaker dependent? In this case, the patient is, and so they would suggest putting the patient into what's called asynchronous mode. So asynchronous mode means the pacemaker no longer cares what electrical activity it sees. It's just going to fire at a synchronized rate, usually, depending on the manufacturer, anywhere between 75 to 100 beats per minute. Okay, I'm already making this too complicated. Usually, if you put a magnet on the device, most pacemakers, they will go into an asynchronous mode, and that way you can assure yourself that you're not missing any pacemaker beats. So you can either put a magnet on it, or you can have a rep come in. So I'm going to put needs asynchronous mode, because I can spell. Okay, but that gives you a relatively quick explanation. You can say, hey, so first of all, this patient has a pacemaker. Patient's pacemaker dependent, electrocautery is relatively close, so I think this patient needs to be placed in an asynchronous mode. I would plan to place a magnet on the device. All right, so good job, guys. I don't want to get too much in the weeds on this since we have a few cases, but I just want to kind of display switch or magnet effect on pace presence of manual pacer in the OR. Yeah, sure. All right. So next topic, what would you guys like to do for pre-induction? Okay, sure. We already got an EKG though, right? All right. This is getting a little trickier, just because we're not quite yeah. So that's a question, is whether or not we would do an arterial line. I think you could say, sure, pre-induction art line. Sure. Sounds good. Anything else? You can do labs if you'd like. If they're on a G1, sure. Let's just consider what's already been done for this patient. Someone brought up the GLP-1 agonists. Those are nice. Probably don't need it pre-induction central line. The other one I'm just going to go ahead and throw out is I would just go ahead and say place magnet. You'll probably want to place the magnet prior to the induction so that you know, one, if the magnet actually works and the patient actually goes into an asynchronous mode. Another helpful point is if you put it in asynchronous mode, the heart rate goes to 100 and the patient says, I have chest pain, then that's probably a problem. Next question is induction of anesthesia. What induction medications would you got? And I know you guys are throwing out a lot of questions here, but just in the interest of making sure we don't get behind, I want to keep going. What induction medication would you like to give? Remifentanil. You could do that. Etomidate. Yeah, I think a propofol or etomidate. I'm just going to write standard induction here. I think a standard induction is totally reasonable. Airway plans. Don't make it hard. Yeah. Yeah. DL endotracheal tube. There you go. Cool. I'm trying to show you that it's not, this is something that you guys can all do relatively quickly. All right. Maintenance. What do you guys want to do? John Kraus got it. SIVO. Love it. Yep. SIVO. Everyone loves SIVO. It's the easy answer, right? Sevoflurane for your maintenance. And what would you like to do for your lines? I guess we already have an art line. Central line's totally reasonable. You can do central line. In our institution, we usually do peripheral IVs, but that's totally fine. And next is emerge. Yeah, and you can, I'm trying to keep it simple. Yeah, you can do these different types of fancy monitors, BIS and all this stuff. I'm just trying to cut to the fat about what's most important in these cases, because you don't want it so wordy if you're trying to present it. You want it to be relatively quick. So, but these are all good questions, and I kind of want to speed through these because I want to talk with you guys about this. But anyways, what about emergence? Pain plans? Yeah, that would be my choice. We'll say hydromorphone. Extubate. Yep, agreed. Okay. Extubate. Okay, so the reason I know that was kind of painful, but the reason I made you kind of walk through that, you guys, is to show you guys that you guys can come up with a plan, and a relatively simple one that still shows that you know what's going on. So, now you can say, okay, this patient has a cardiac pacemaker and is pacemaker dependent with how near the electric cautery is. I think the patient needs to be placed in an asynchronous mode with a magnet. Prior to putting the patient to sleep, I'd like to check some labs, place the magnet, and place an awake arterial line. For induction, we can use a standard propofol induction with direct laryngoscopy to place an endotracheal tube, use sevoflurane for maintenance, placing a central line after the patient's asleep, and we can use hydromorphone for pain control at the end of the case, and we'll plan to extubate the patient. Again, there's a lot of details in that you are not saying outright, like, the patient probably needs blood in the room, or, how do we monitor volume status, these kinds of things. But my point is trying to kind of focus on the significant problem and trying to keep the case relatively simple. They may ask you additional questions, but if you have kind of the open-ended question and you have the floor, you want to kind of cut to the chase and show them that you know what you're talking about. But all of your questions, you guys, are really good, not to be dismissive at all. I want to keep moving those because I don't want to slow this down. Just to review, pacemakers, another topic people make way too hard. I think we already reviewed this. Take a look at the diagram in the book. ICDs are a different animal, but basically, if the electric cautery is far away, you don't have to do anything. If it's close and the patient's not pacemaker dependent, the book says you don't have to do anything. If it's close and the patient is pacemaker dependent, you'll need to be placed in some kind of asynchronous mode. I want to note, though, this is not one size fits all. Not all staff do this. In fact, I don't follow it this way. I do different stuff, but I don't want to lead you astray. Just understand that this is theoretically the direct way to do it. Some people always place a magnet. Some people never place a magnet until they have to, just so you guys are aware. But in the end, though, you only have a few choices, right? You either place a magnet or you don't, or you call a rep. Everyone gets all wound up with what mode is it on? Is it DDD? Is it AOO? Is it DOO? You know, all this stuff. Just everyone's basically DDD all the time unless you put them in asynchronous mode. That's not really important though. The point is clinically, you only have like 3 options.